Next presentation is micropulse laser, a treatment option in chronic central CSR by Dr. Usha Shree.
Good morning, one and all. I would thank the dignitaries on the dais for giving me this opportunity. My number is U17903. I would present a study on micropulse laser, a treatment option in chronic central serous chorioretinopathy. Now, as we all know, chronic serous chorioretinopathy is idiopathic, happens mostly in young male in the second to third decade. Risk factors being type A personality, corticosteroid intake in any way, hypertension, stress, and pregnancy. The current management option, since the disease is idiopathic in nature, mostly it is observation in the acute period because it is a self-resolving disease. Other management options are focal laser to the leaking PDDs, photodynamic therapy, intravitreal anti-VEGFs, oral eplerenone, and other few medications. As we all know, focal laser and photodynamic therapy have few changes on the retinal pigment epithelium. There are chances of laser scarring, expansion of the laser scars, and chances of choroidal neovascular membrane in the later stages. So the next would be micropulse laser. It's a 577 nanometer laser in the micropulse mode in the yellow laser to produce a therapeutic response without inducing any intraretinal damage which would occur with the conventional lasers. So the current study was to investigate the role of micropulse laser in treating this chronic CSCR. So this was to study the safety and efficacy of the micropulse yellow laser in the management of chronic CSCR as a primary treatment option in these patients. So this was a retrospective observational case series of 12 eyes in patients with chronic CSCR. Every patient underwent a detailed ophthalmic evaluation and OCT analysis was done at baseline, 1 and 3 month interval after micropulse laser. Main outcomes studied were mean change in the visual acuity and also the height of the subretinal fluid. We included any patient with CSCR with the with the 3 months duration at least, and excluded all patients with acute CSCR presentation and patients with post-lasered CSCR. So the parameters for micropulse laser in our hospital, we would keep a power of 400 to 500 milliwatts, duration of 200 milliseconds with a 5% duty cycle and an interval being a pattern laser. So this is the laser console picture showing duration of 200 microns and power of 500 milliwatts with a 5% duty cycle, with a grid pattern of 4x4 and 0 spacing. That is very low intensity burns with a high density spacing. So total of 12 patients were seen, where male were 10 and female were 2 patients. The logMAR improved from a baseline of 0.58 to first month at 0.5 logMAR, and third month with visual acuity improved to 0.46 logMAR. Similarly, the height of the subretinal fluid also reduced from a baseline of 261.4 microns to 222.71 microns at first month and to 138.42 at third month, and it was maintained even at 6 months. So this is a case where 47-year-old male who presented to us with reduced vision for more than 6 months duration with a vision of 612 with a good subretinal fluid subfoveal area. After 2 months of laser, the vision improved to 6.9 with reduction of the subretinal fluid. A case 2 where a male of 25 years was seen with reduced vision for more than 3 months, and vision was presenting at counting finger 1 meter with a good subretinal fluid and hyperreflective dots on the OCT. After 2 months of laser, vision improved to 636 and there was resolution of subretinal fluid. This is a 48 years old male with a previous 2 to 3 episodes of chronic CSCR in the past history, with few RPA changes seen clinically, reduced vision for presenting for the third time for more than 8 months duration, and vision was 636. After 8 weeks of the micropulse laser, vision improved to 624, but the RPA changes was there, so vision did not improve further. So total of 12 eyes, complete resolution of the SRF was seen in 3 cases. Significant reduction was seen in 50% of the cases, and there was no resolution of fluid in another 25% of the cases. So micropulse laser in the yellow spectrum of 577 nanometer produces a therapeutic treatment without inducing any intraretinal damage. In a conventional laser mode, the laser power is on for the complete period of the duration of the laser, whereas in micropulse mode, it is a train of repetitive short bursts of micropulse energy, where of 5% duty cycle, where only the 5% of the laser time on time is only 5% and remaining 95% is the off time. So in a 200 millisecond duration, only 100 microseconds is the duration where laser is on, and the remaining duration the laser is off. So there is sufficient time for cooling effect, and hence there is no increase in the thermal elevation. So when we went back to the published studies, Scholz in Ophthalmologica 2015 presented a paper on subthreshold micropulse laser treatment in chronic CSCR, where they did it on 38 patients with 577 nanometer micropulse laser for chronic CSCR, and also a subgroup of 18 patients who had persistent fluid after PDT. In the follow-up, 74% of the first group responded to the therapy, and even in the subgroup PDT, 61% had responded. They concluded that subthreshold micropulse laser is effective even in patients without sufficient improvement after PDT. In our study, 75% of the patients showed significant reduction in fluid. Yadav et al. In 2015 presented a paper on yellow laser treatment in chronic CSCR, where 10% duty cycle was done. Both focal and diffuse areas were treated. We had done diffuse area all through the macula. In the follow-up, in their study, 79% had average reduction of height. In our study, with even a 5% duty cycle, 75% showed reduction in the fluid. In the post-laser details, there were no retinal pigment epithelial changes. There was no inflammation or any exudative retinal detachment, no retinal damage or burns which are clinically noticeable, and there were no cases of any retinal pigment epithelial rip in patients with larger PEDs. So to conclude, micropulse laser is a safe and effective alternative treatment option in the management of chronic CSCR where the other treatment options have failed. Thank you.
Why that large spot size?
Sir?
Why did you use the 200 micron spot size?
200 micron spot size basically to cover the entire area of the macula, and very low intensity, high density burns were, so literally sparing the fovea, the entire macula was treated.